Good morning, everyone. Good day, everyone, I should say. My name is Ali Thwaini. Thank you, Vina, for the kind introduction. I'm a consultant urologist, work currently in Mediclinic City Hospital, and I would like to thank you, everyone, actually, who made the effort to listen to my talk. Greeting from the other side of the Atlantic. So my talk is going to be about the basically general men's health. And the upcoming month, or this month, is November, hence the name November is a month of the mustache. So it's a special emphasis, about the men's health, and I would hope that by the end of this talk, I will be addressing the pertinent issues for men's health. I'm going to start with the learning objectives. Vina, if you wouldn't mind. So the previous slide was my actually work in Belfast City Hospital. So the learning objectives, I'm going to talk about the prostate cancer. So again, thank you. Incidence or risk factors. We're going to talk whether to screen or not to screen for prostate cancer. We're going to talk also about testicular cancer. We're going to talk about the men's sexual health, and we'll give a take-home message. So we'll start by talking about the prostate cancer. What's the prostate? So the prostate is a pear-shaped gland which is present in a deep side of the pelvis of men, and it's underneath the urinary bladder, and you see it's kind of glowing in the picture there, and it's like a donut squeezing on the water pipe, but no one really understands what the function of that gland is. So I'm going to talk to you about the function. The first function is defense. So the prostate has an antibacterial factor that protects the sperms and provides healthy environment. When I speak about healthy environment, it provides also nutrition, as you can see in the next picture. So it provides lots of nutrients, zinc, selenium, vitamins for the sperms. And the other important function is actually, it paves the way for the sperms to penetrate the ova and induce conception. The ejaculate is very thick to start with. If you leave it half an hour outside, it becomes water, and that's because of an enzyme called PSA, as you will see now. So the PSA is an enzyme secreted by the prostate gland, and its P stands for prostate-specific antigen. It's not cancer-specific. The PSA normally leaks into the bloodstream in men. Hence, we'll always find some value of the PSA less than 4 normally. And it goes up with a variety of conditions. So one of them is prostate cancer. So I'm going to talk to you about the incidence of prostate cancer. So the following slide will show you the incidence. Actually, 1 out of 9 men will be affected with prostate cancer during their lifetime. And it's a cancer of aging men, or men, getting older. So at the age of 60 or 65, 6 out of 10 will be diagnosed with prostate cancer. And the average age of the diagnosis is 66, as you will see from the next sentence. So if you follow the next slide, so this slide, for example, shows you the prevalence of prostate cancer around the world. So the dark red is where more prevalent, so in North America, and then on the other side of the globe, Australia, New Zealand, it's less common or less diagnosed, I should say, in the Middle East and Africa and South America, and much less in Asia as well. And if I show you the next slide, this one is the histogram. So the light blue shows the incidence, and the dark blue is the death from prostate cancer. So if you look at the USA, for example, there's a huge amount of incidence, while the death or the mortality is, is very low. If you compare that to a country like Zimbabwe, much less incidence and almost equal mortality, if not slightly higher. And that has 2 explanations. One of them is either the Americans are brilliant and they are diagnosing prostate cancer, and that's why preventing death, or maybe they're overdiagnosing prostate cancer, because you'll soon know that prostate cancer is not all fatal, as the tigers and pussycats. So we need to be really clever when we decide to screen. So the next slide is really to screen or not to screen. There are advantages and disadvantages. How do we screen for prostate cancer? Clinical examination, rectal examination using the digit, and of course the PSA test. And it comes with its own pros and cons, as we'll see from the next slide. Actually, for a screening program, you have to screen an important health problem. You have to know the natural history of it. The screening tools should be safe and effective with minimal side effects. And of course, you should be aware of the treatment. That's what constitutes a healthy screening program, or a cost-effective one. Excuse me. So when it comes to prostate cancer, I'll show you the advantage and disadvantage of the screening. So the next slide will show you. So the pros, if we screen prostate cancer, we have earlier diagnosis, chance of cure. Sounds really easy. Well, actually, it's not, because screening could induce anxiety. The tests are not trivial. If you do a biopsy, there's a risk of infection. the tests are not 100% accurate. As I said earlier, the PSA stands for prostate specific. It's not cancer specific. So it goes up with a variety of conditions. So if a man walks to me and we do a PSA and it's elevated, that creates an anxiety. And of course, the overdiagnosis as well, as we saw from the histogram about, the America. So the next slide, I'll show you what I mean about the tiger and the pussycat. So if you look at the prostate cancer on the next slide, so on the left side of the screen, you could see it's low risk prostate cancer, low PSA, the cells are not aggressive, and that we tend to leave alone. So I'll give you an example. If a 75-year-old man with diabetes, hypertension, heart failure was diagnosed with a low risk prostate cancer, well, we tell them you have cancer, but there's no need for treatment. We just keep watching it. On the other side of the spectrum, a young, healthy man in their 50s, for example, having a PSA in the teens and aggressive cells, we definitely have to treat them. We have to be aggressive in the treatment. So there are the tigers and the pussycat. There are so many trials have gone, to discuss whether screening is a good tool or not. And I don't want to bore you about the details of these slides, but I just want to show there's so many trials that have gone. So this slide and the following slide is showing just a number of the trials that have gone. But I want to discuss two important trials that are fairly recent. So the next one will show you is called the PLCO, the Prostate, Lung, Colorectal, and Ovarian Trial. So that's an American trial. It's a prospective one. They looked at 77,000 men. They split them into two groups. And then at the end of 9 years, they found that those who are screened having daily examinations and PSA, basically we could have slightly increased the detection, about 12%. So they came to the conclusion that actually screening is a useless tool for prostate cancer. The problem with this trial, as we'll show you, 50% of those not supposed to be screened, they jumped across to the back door and they had their PSA tested. So the trial actually lost its validity. On the other side of the Atlantic, however, the Europeans did a much better trial. So at the same time, they looked at 182,000 men, equally divided between two groups, screen and non-screen. So just to clarify, those who are screened, they had their regular PSA rectal examination. Those who were not screened, they were just registered in the trial. At the end of 9 years, we checked. And actually, in that trial, they found that we could actually reduce prostate cancer mortality by 20%. That sounds amazing. However, when it comes to screening, we have to look at the logistics. So for the next slide, we'll show you. At 9 years, this trial found that in order to save one life, you would have to screen 1,500 men almost, treat 48 men, and then save one life. Now, for one life is important for you and me because it could be us or it could be our, a family member, for example. But for a trial, this is probably not cost effective. However, the next slide will show you something interesting. The trial finished at 9 years, but the researchers kept on following the same two groups. And they found that the more they followed the screening group, they found more and more prostate cancer, and they could save more and more lives. So I'll show you the next slide, that at 9 years, as I said, you have to screen 1,500 men, treat 50 to save one life. But if you drop down to the bottom of the table, that number actually came down to only just above 500 men to screen and 18 men to treat to save one life, which is quite brilliant. How do we compare with other cancers? So the next slide will show you comparing the prostate with other cancers like the cervix, the breast, and the colorectal. And actually, it's a quite powerful contender. So at the 16 years, we might be able to screen for prostate cancer. So following slide. So whom to screen, really? At the moment, as of today, we cannot really justify mass screening, but we do what's called opportunistic screening. So it means that men with positive family history of prostate cancer, or men above 50 and they're well informed, like, listening to this lecture, for example, decide to go for a screening, or any man above the age of 40, but risk factors like positive family history with dad or brothers affected by it, they ought to be screened. Following slide. The other thing is the PSA value. When I came to the UAE, actually I came across an interesting observation. We normally see the PSA above 4 and below 4, but I noticed that actually the cut value of PSA is quite low in Middle Eastern men. So I searched the literature and I came across this Saudi paper, and they searched actually 7,000 men, and they found that actually their median PSA is lower than the normal. And the trial advocates that if we screen for a lower PSA, we could actually detect earlier cancer. So it's a very interesting thing, and I would say just watch for the space for the near future. So in conclusion, at the first session of our talk, mass screening, I should specify, I think the over-detection currently weighs heavily against the benefits. So we cannot do mass screening for prostate cancer, but we definitely have to target high-risk population, as I mentioned. because it will show benefits of screening. And maybe in the near future, we may consider lower PSA when we screen. So we finished the first part of the talk. The second third of the talk is about testicular cancer. I'm sure you know the character on the left side of the slide is Lance Armstrong. He's an Olympic cyclist, and he was diagnosed with metastatic testicular cancer that has spread to his bones, to his chest, to his brain, and he's still alive. He's a good example. So the next slide will show you the prevalence of testicular cancer. If you look at the above map, so the darker is the higher prevalence, so North America, Australia, New Zealand. But if you look at the lower one, the mortality, actually the countries where the testicular cancer is more prevalent, the mortality is less. And that shows you that, early detection of testicular cancer is the essence of cure. And you remember what I said about the tiger and the pussycat and prostate cancer? It's all tigers and testicular cancer. So the next slide will show you. I don't want to scare you, of course, by mentioning testicular cancer. There's so many lumps in the testes, but they are not cancer. Like the first picture is a hydrocele. It's just a fluid, but it shows up a lump. The next one is a varicocele, dilated veins. Again, you see swelling. That's not cancer. And the third one shows it's called spermatocele, a cyst, and definitely you feel a lump, but it's not cancer. And the fourth one is actually a hernia. It's not even in the scrotum. It comes with the gut goes through an opening, and that's not cancer. But the most important thing is the next picture, which is the periodic. Sorry, then actually that's the cancer. So you could see that the testicular cancer is very uncommon. But I would strongly encourage that every young man, every man actually, should have periodic self-examination, as you could see in the next picture. And that's very important. And if you feel anything abnormal, you should go to your doctor. So the next slide, I'm going to show you the graph. And the graph is very interesting. So if you see the blue line is the incidence of testicular cancer, and the red one is mortality. So until 1985, the incidence and the mortality were going up and up. But something happened in 1985 and the mortality dropped down significantly. And the hero is cisplatin, and that's a chemotherapy. So I put actually Superman on it, on cisplatin, if you see the next slide. So cisplatin, actually, when it came, it converted a fatal disease into a curable disease, and that really shifted the paradigm. And actually, I stand as a life example of testicular cancer. I was diagnosed at the age of 27, and I'm 51, alive and well. So in conclusion, I would say what used to be a fatal illness is now proven to be largely curable disease. Education leads to early detection. Early detection leads to cure. And periodic self-examination is really essence to early diagnosis. So we finished the second third of the talk. And of course, I would like to quote Lance Armstrong. He said, "Pain is temporary, quitting though lasts forever." The third talk is probably a very important one. We're talking about the men's sexual health. Men are generally very proud creatures, and they wouldn't talk about this because it's a very private matter. However, it's not uncommon, and sexual dysfunction means basically the inability to perform erection that's sufficient for successful intercourse or partner satisfaction. When we look at the incidence of sexual dysfunction, according to the Massachusetts Male Aging Study, they looked at more than 1,000 men, and they found that 40% of men in their 40s, they have sexual dysfunction, and that goes to 70% of men in their 70s. And there are several causes, for sexual dysfunction. We have the organic, from blood vessels, from nerves, from hormones, from drugs, drugs for diabetes, hypertension, alcoholism, drug abuse, unhealthy lifestyle. And of course, the psychological factors. We have the performance anxiety, if you have a marital or partner relationship problems, depression, sexual trauma, work-related stress, anxiety, all these. So many factors, actually. But the most important thing, even though sexual dysfunction in men is a disease, but actually could be an early symptom of an underlying serious disease. So it's more often than not, a man walks to our clinic and we find that they are diabetics and they haven't been actually diagnosed, or they have an ischemic heart disease, for example. So, and the first presentation is actually sexual dysfunction. Next slide, please. So how do we, slow down, please, go back to the previous slide. So the most important thing, really, half of the treatment is going to the doctor. And we start the treatment by modifying lifestyle. Exercise is very important. heavy, we're talking about resistant exercise because that will build the muscles. We're not talking about cardio. Cardio is healthy, but for sexual dysfunction is resistant exercise. And that will increase the muscle mass and leads to increased testosterone. Smoking is a killer for the man and for his valuable member. Medications, so if there's any drug history, we just need to alter it because some of the medications, they cause sexual dysfunction. And of course, weight reduction. Our disease at the moment is not a diabetes, hypertension. Our disease is a chair. It's a sedentary lifestyle. We're sitting behind a chair, eating junk food, sleeping less, getting stressed, increasing our body mass index and having a lot of the insulin resistance, and that's a problem. Next slide, please. So the treatment, we spoke about the lifestyle. The next thing is the medical treatment. The first treatment actually starts with injections. If you look at the first picture now, it's coming. Okay, so that's the injection of prostaglandin inhibitor. So it's a Professor Virag, actually, he injected himself in a conference in front of the audience, and he induced that he could have an erection. Now, the injected treatment is very good, but actually it's cumbersome. You have to inject yourself before every intercourse. It wasn't until the late 90s where actually the Viagra was discovered and the Cialis, and that made a massive shift in the paradigm. And actually, sexual dysfunction has improved dramatically. And then other companies worked centrally on the brain, apomorphine, but that didn't take off very well. And then there are some investigational treatments like the Botox, and of course, then regenerative medicine, the PRP, and the stem cells, as you'll see in the next pictures. And of course, there is also the physical treatment. So this is what's called a vacuum device. So basically, the vacuum device is for men who do not want to take any medical treatment. It's a device that's applied to the penis, and basically the negative pressure leads to engorgement of the blood supply, and hence an artificial erection is performed. And then the ring, the band, if you see there's a plastic band, you squeeze it down at the base of the penis, and that will trap the blood for enough time to have sexual intercourse. But some men find it quite cumbersome as well. The next thing is another type of physical treatment, that's shockwave. So if you imagine if you get slapped on the wrist becomes red because mechanical trauma induces an acute inflammatory reaction, and that increases the blood flow. And that's the whole idea of the shock waves. So trauma will induce inflammatory reaction, increase blood supply, and leads to a better erection. And it's an office-based procedure. And actually, this procedure now is easy, and it's part of the European Association of Urology guidelines. Next slide, please. The next one is, now we're talking about regenerative medicine. So one of them is a platelet-rich plasma cells. So we take blood sample in the office, we centrifuge it, we take the precipitant, which contains platelets and their rich growth factors and growth hormones as well, and vitamins and minerals. And actually we inject that into the penis, and that could induce better erection. And that's, it's regenerative, it's not only repairable. And there is evidence, emerging at the moment that is supporting this kind of treatments. And the beauty of it is an office-based procedure, which we provide. If we go further, we talk about the stem cells. The embryos, they are full of stem cells. And even us adults, we have stem cells in the fat and the bone marrow. So these stem cells, if you take them and put them in a tissue of an injury, they will change their architecture, they alter their identity into the damaged cells and repair them, which is amazing. But it's still investigational. It's still carried out under trials. And speaking of which, if you see the next slide, we are actually in the process of applying for a research proposal at the Mohammed Barashi University, and we are in the process of getting ethics approval. So in conclusion, I would say men's lack of sexual health is not to be underestimated, and actually, erectile dysfunction or sexual dysfunction could potentially unearth an underlying serious health issue. Early detection could always remedy any irreversible damages. And I would finish with the next slide.
Yes, doctor, there are a couple of questions. I'll read out the first question for you.
The next slide is basically early detection saves lives. So I'm ready for, thank you so much for listening. I'm ready for the questions.
So, Doc, the first question is, have developed an issue of enlarged prostate at relatively early age of mid-40s. What lifestyle changes would you recommend for people suffering from enlarged prostate, and when should one go under the knife?
Okay, so very good question, actually. You know what? Actually, prostate starts to grow when we are in our 30s. If you draw a curve, the growth spurt of the prostate is actually in our mid-30s. So I wouldn't be surprised if see a man with an enlarged prostate in their mid-40s. Now, if it's enlarged, it's not causing any symptoms, I would say do nothing, because with all due respect, some people have big feet, some people have small feet. But if that enlarged prostate is causing problems like, frequency of urination, going more often to the toilet, waking up at night, having difficulty, you have to strain to pass urine, then I would say eating healthy food, minimizing, for example, the coffee and tea, because that contains caffeine and that irritates your bladder. Try to eat cooked tomatoes and asparagus and green vegetables because they contain a lot of zinc and selenium. So palmetto is another thing. The nice um, the small like the white stuff that you eat like so palmetto. And that's really really helpful. So if you want to stick with the lifestyle and herbal treatment.
Doc, the second question is, what could be the causes and causes of this condition, let it be testicular or prostate cancer? If you could elaborate a little bit, and what are the do's and don'ts?
By all means. So let's talk about prostate cancer. Prostate cancer is a disease of man. So the risk factors are being a man, okay, and the other one is increasing age. Now the other important factor is ethnicity. So prostate cancer is different between different ethnic groups. It's more common in Europeans and Northern Americans. Also, it's common in Africans, less common in Middle Easterns and Asians. The other risk factor, of course, is family history. So if you have a family member, a first degree relative like a father or brother is affected by prostate cancer, you are probably have the double chance of developing it in the future. Um, how to prevent it? As I mentioned earlier, the most important thing is probably if you belong to the high risk group, I would probably suggest to get checked by the doctor, simple clinical examination plus blood test, and that will keep you safe. And as I mentioned earlier, in terms of the lifestyle, the cooked food, cooked tomatoes, avoiding high fat diet because that's very unhealthy, reducing weight, improving exercise because all of these will minimize the insulin resistance. Because once you develop insulin resistance, then you have recurrent inflammatory reactions, and of course you have production of free radicals and precancer cells. For testicular cancer, the main risk factor is undescended testis. So if you were born with a testis that's actually in the tummy and that has come down to the scrotum later on after the age of 2 years, then there's a slightly higher chance of developing testicular cancer. Positive family history is a very weak correlation. So to be honest with you, thankfully, testicular cancer is not that common. It's not as common as prostate cancer. And the other good thing is that testis is an external organ, so it can be easily examined by the individual. And if you feel any lump or bump, you can always go to your doctor.
Mr. Doc. Doc, the next question is there any relationship between obesity and testicular cancer and prostate cancer?
The answer is unfortunately yes. So obesity leads to insulin resistance, and that will lead to recurrent inflammatory reactions. And the inflammatory reactions lead to release of what's called oxygen-free radicals. And these are precancer cells. They will alter the metabolism of the cells, and they will lead to cancer. And many, many studies have shown that actually there is a high risk of cancer developing in people with high BMIs. So the answer is yes. But the good news is it's always a reversible thing. Once you adopt a healthy lifestyle, healthy food, regular exercise, and guess what? Sleep. Sleep is one of the most important healthy things that we can do. You can imagine by doing nothing. So you need to sleep between 6 and 8 hours a day. I'm talking about proper sleep. I know all of us are getting stressed. Well, I'm across the Atlantic at the moment and I can hardly sleep, but I'm definitely willing to catch up on my sleep when I come back to the UAE. So I hope that I answered your question.
Stop. Next question is, what vitamins do you suggest or daily health nutritional changes? What would you suggest to prevent such conditions?
Green leaves, vegetables, minimizing the eat of high fat Meat as well. Meat is not very healthy, but obviously it's important. So I would say probably stick down to meat like once, maybe twice a week, and the rest would be like vegetarian, for example. The other thing is now there's, I mean, even though it's out of my remit, but there's a lot of trend about what's called intermittent fasting. Studies have shown that if you refrain from eating food for more than 16 hours, so you just stick to drinks, for example, like water or other non-calorie drinks, your body will have the chance to actually to regenerate, and the scavengers of the body will start eat the dead cells and the precancerous cells. So I think that would be a very important thing to adopt. It's called intermittent fasting. Try that. I did, and actually it was very useful.
Doc, next question. Does smoking have any direct correlation between these cancers?
Yes. So smoking contains, especially like the normal cigarette smoking, we're talking about 50,000 harmful materials, and most of it, not a trivial number of these materials are actually precancerous. There is no strong relationship between smoking and prostate and testicular cancer, but definitely there's a higher incidence of cancer in general. So, for example, smoking and lung cancer, they're very strongly correlated, or smoking and bladder cancer, they're very strongly correlated. It's less correlated with prostate testicular, but definitely has a higher risk.
What are the necessary tests for men in their mid-40s if family history existed?
So, a man in their 40s with family history of prostate cancer, I would say visit the doctor, get the prostate clinically checked by just rectal examination, and then have a PSA, the blood test. Now there's a new thing which is called micro ultrasound. It's a very simple ultrasound office-based procedure, and so it has a very high frequency that could actually discover any lesions in the prostate. Now, I wouldn't recommend it for every man, only for those with abnormal blood tests. So as simple as a simple clinical examination, office-based, and a blood test. That's the only thing I would suggest.
What are the alarm signs of prostate cancer?
A very good question. Prostate cancer actually doesn't cause any particular symptoms, especially when it's early. So men with early prostate cancer will have exactly the same symptoms of men with no prostate cancer. So could have symptoms of no symptoms at all, believe it or not. So we discover it just by coincidence, people coming for screening and we discover it. Or men could present with symptoms of a simple enlargement of the prostate, like frequency of urination, difficulty in passing urine, dribbling, interrupted stream, waking up at night 2, 3 times, urgency, all these symptoms. But these are not specific for prostate cancer. These are specific for prostate enlargement in general, which could be cancerous. When the cancer gets really advanced, God forbid, then it spreads to the bone. So men present with advanced symptoms like weight loss, bone pain, cachexia, all these things. But thankfully, we're seeing these kind of symptoms much less common nowadays because of early detection.
Noted. So there is a next question, which is actually related to insurance. I'll pick that question. Under our insurance, it's covered. How we can go for this test? Annual prostate cancer screening includes clinical exam, PSA, rectal sonogram. So the first, I'm not sure which insurance you have or which corporate you belong to. The first thing to do is you have to check with your HR or your account manager from Alpha Team Release to check whether this health checkup is under the policies on direct billing or is on reimbursement. Once it is confirmed, you can go ahead for any provider in the market and you can do your testing and submit it for reimbursement or direct billing, however the setup is. Going to the next question, Doc, for you. Till now, I have not examined myself, but all seems fine. Which food is best to avoid and fight cancer that we can add daily?
Which food we avoid best?
Which food is best to avoid so that it fights cancer? And what are the food which need to add daily in our diet?
Yeah. So, I mean, avoid is a big term. I would say minimize probably animal fat, like red meat and, undercooked meat, for example, with lots of animal fat. That's probably is better to minimize, because that could, could lead to all these harmful effects, including also diabetes, hypertension, everything. Increasing the type of food to increase. So the pumpkin seeds, that's where I'm trying to remember the word actually. So pumpkin seeds are really essential source of the soap palmetto, which is amazing. Then asparagus, cucumber, like all these things, vegetables, they're very, very good. Cooked tomatoes, also, they're a very healthy source of food as well, like minimizing table salt. So these are the things that you would probably want to adopt. And going back to the point whether the screening is covered by insurance, I would say most of the time it probably is. So just a comment.
So, Doc, we have covered almost all the questions. We will just wait for another 5 minutes for any questions to come. Or okay. There is a question that please can you replay on this webinar? So just to let you know that this webinar is recording enabled. So if you click on the same link which you got from the flyer, after this session, you can refer to the recordings as well. So you need not do anything. It is just that you click on the link on the flyer and you can refer to the recordings. I understand your queries on coverage uh, the uh, for annual prostate cancer. It comes from Aban Insurance. So the right thing to do is either contact your HR or your account manager to get the details of the insurance and the setup, and they can help you out further. So we have taken all the questions so far. Doc, there is a question. What is the difference between prostatitis and prostate cancer?
Okay, that's a good question. So prostatitis, from the name, whenever you hear the name itis, this means like an inflammation of an organ. So prostatitis is an inflammation of the prostate gland. And there are different types of prostatitis. There's an acute and there's a chronic, with or without bacteria. And prostatitis is a very, very common condition. Believe it or not, 1 in 2 men will have at least one attack of prostatitis in their lifetime. It's not cancer, so it's not dangerous. It's a nuisance because it's easy to treat but difficult to cure. So whenever you have an inflammation of the prostate gland, sometimes we treat 90% of inflammation with medications, but every now and then it recurs. I personally call the prostatitis like the migraine of men. With migraine, it's not sinister condition, but it comes and goes, and when it comes, it's really annoying, and you can only treat it when it comes. And the same thing with the prostatitis. Um, whether there's a link between prostate and prostate cancer, the jury is out. Interestingly enough, in the past, talking about 30 years ago, people said prostatitis does not lead to prostate cancer. Then I would say in the last 10 years, researchers have delved into that again, and they found that actually chronic prostatitis could lead to what's called proliferative inflammatory atrophy, PIA, and that could lead to atypical small cell acinar proliferation and eventually could lead to cancer. So this is only theory. I don't want anyone to panic because prostatitis is very common and it's very unusual for prostatitis to get converted to prostate cancer. But I just thought of sharing this information with you. So prostatitis is a very, very common condition and it's not dangerous and it's different from prostate cancer.
So, Doc, there is a question next, which is related to same subject. Does frequent prostatitis can lead to prostate cancer?
I would say the jury is out. So if anyone is suffering from chronic prostatitis, I don't think he is at risk of developing, at a higher risk of developing prostate cancer, to be honest with you. At the moment, the information is still investigational. There is no hard evidence about this. Sometimes when we operate on prostate, we find that the pathology comes to us and they say, oh, there's an element of prostatitis. And the same thing with the prostate cancer. We get the cancer, the specimen, and they'll say, oh, there's an element of prostatitis, but it doesn't mean that prostatitis has led to prostate cancer. Most important risk factors are, age and family history of prostate cancer, to be honest with you. And so I wouldn't consider prostatitis at the moment as a risk factor for prostate cancer because it's not proving it, it's investigational still.
Next question is sexual disorder related to a sign of future prostate cancer?
That's a very, very important question. Sexual activity was found to be a very healthy practice in men, and actually increasing sexual activity. There's a recent trial where you're talking about, at least on daily basis, could be preventative against prostate cancer. Of course, that's probably practically not possible for most men. So I hope that I answered the question. But sexual inactivity or sexual dysfunction could be a symptom of many diseases. Prostate cancer is probably at the bottom of the list. I think it's most important is to rule out diabetes, hypertension, dyslipidemia, all these things. I wouldn't strongly link it to prostate cancer.
Doctor, there's another question. A tinkling pain in the right side of the back, can it be related to prostate cancer or kidney problem?
So, I mean, the back itself, any pain in the back could come from a variety of conditions. So you have muscles, you have bones, you have nerves. We call it musculoskeletal, and that could lead to a bit of tingling. Then you have the gut. So, for example, on the right side, you have the ascending colon. Left side, you have the descending colon. Then you have, of course, the kidneys on the right and the left. It's extremely unlikely that a tingling pain in the back, for example, could be a sign of prostate cancer. However, of course, you need to put that in a context. So, for example, if a 50-year-old man or older comes to me with this kind of back pain, I would normally ask about if they have any urinary symptoms, and I would definitely offer them a prostate health check at the time of the clinic.
Thank you so much, Doc. We have covered all the questions. Thank you so much for your time. It was a really informative session. The reason to organize such sessions is to create the awareness, to how important early detection is important so we can have a good outcome. I hope it was very informative for our audience also. Just to repeat that our flyers which we shared, it's a recording enabled. So just in case if you are not able to attend to this session in full, you missed some part of it, or you want to hear it again, you can click on the same link to hear it again. Thank you so much, Doc. Have a nice day.
Thank you so much, Bina. Thanks everyone for listening. Thank you. Have a good day.